Hello, everyone, and welcome to this presentation presented by the Visiting Nurse in Hospice for Vermont and New Hampshire. Let's Talk, our monthly meeting. So my name is Anthony Knox, and I am the Community Relations Manager for the Visiting Nurse in Hospice. And with me today, we're going to be talking about the Community Nurse Connection with their Executive Director, Kristin Barnum. So Kristin, please give yourself way more of an introduction than I did.
Thank you, Anthony. Thank you. Yeah, it's great to be here. I appreciate the invitation. I'm Kristin Barnum. I mean, the first thing you should know is I am a nurse. I've been a nurse for, over 25 years, and most of my nursing career has been in hospice. Currently, I'm the Executive Director for Community Nurse Connection, formerly known as Upper Valley Community Nursing Project. So about a year ago, a little over a year ago, we changed our name to Community Nurse Connection for a few reasons. Number one, we realized we're no longer a project. And two, we're supporting nursing programs outside of the Upper Valley. And another little bit about myself and why I love community nurses is it's almost like pre-hospice. You know, in hospice, you have to have a life expectancy of 6 months or less. And this is really providing that holistic care when you don't qualify for hospice care. So happy to be here.
Awesome. Well, thank you so much, and yeah, thank you for reminding us all that that the name has changed, and I would for sure say that you guys are not a project anymore. You're a full-fledged organization that is providing great support across the areas that you're providing support, which we'll get into momentarily. As far as where everything is. So I'm gonna let you start driving this presentation, and we'll go from there.
Thank you so much. As I mentioned, we used to be Upper Valley Community Nursing Project, and this is the first time I've presented with our brand new logo that doesn't have that in the tagline. So we're very excited that we rebranded and we're using our new logo with our new website. So thank you. All righty. As Anthony talked about, we are, and I mentioned, we're much bigger than the Upper Valley. So I thought I'd start with a slide of where our current community nurses are supporting their residents and clients. So in Vermont, actually new this year, we have a Tunbridge, Vermont, Heartland, which has been in operation for over 6 years, Norwich, Vermont, Reading, West Windsor, Thetford, Weston, Londonderry, South Londonderry, Peru, Vermont, Landgrove, and Andover. Also not on this slide, Stratford has a community nursing project. They don't have a nurse yet, so this is kind of a plug. If you know anybody that is interested in a community nursing position in Stratford, Vermont, you can either email myself or go to communitynursestratford.org and apply for the job. In New Hampshire, we have programs in Hanover, Lebanon, and Lyme. And then starting January 1st, Grantham and Enfield. Grantham, it passed by a town warrant article. They will start community nursing in January 1st, and Enfield is currently fundraising for the position.
That's awesome.
So those will be posted. The other thing I want to add is Hanover has just increased their hours. So they're looking for a second nurse in Hanover.
And so with all of these towns that the community nurses are currently in and things like that, what are kind of the average amount of hours that they're able to provide on a weekly basis to individuals in those communities?
Yeah, it's a great question, and it's kind of all over the place. Most communities start with about 10 hours a week, 10 to 12 hours a week. And then as they assess the needs and the nurse gives feedback, they usually quickly increase. So I can say Lebanon, the city of Lebanon has 2 nurses, they're 20 hours each. But then if you look at Norwich, they're at about 13 hours a week. So it's a little all over the place based on the community need and the community resources.
Gotcha. Okay, perfect.
And if you want contact information for the nurses in each of these towns, I used to do slides with all their contact information, but then as soon as I made the slide, it was outdated. So I encourage you to go to communitynurseconnection.org. There's maps with contact information you can print out if you like to pin it up on your desk, or you can always go back there to see if there are new programs.
Perfect. Yeah, I will say your website is actually very, very easy to use and super informative to be able to find specific people, and even if even if you're not in one of these towns listed, I know that the community nurses are always willing to reach back out and hopefully maybe steer you in the right direction of services and supports and things like that, to be able to help out.
Yeah, thank you. I appreciate that. Okay, so kind of a little bit about what a community nurse does. And I want to highlight that this is no cost to the clients, and it's not billed to Medicare, Medicaid, or private insurance. So instead of really reading the list of what the nurses do, I always like to tell a story instead. And some of you may have heard my story, but it is a little story about Jack and Diane. Jack and Diane live in town, and they have both lived there their entire lives. They're in their 80s. They don't have children. Diane has some chronic illnesses. She has diabetes, congestive heart failure, as well as some other conditions. And Jack recently was diagnosed with dementia, and his doctor told him he shouldn't be driving anymore. So Diane has heard about the community nurse from the town website and the town newsletter, so she calls and asks if the nurse can come over and visit. Community nursing isn't urgent care, so the nurse makes an appointment to see her the next week. While she's there, she notices that Diane is on 12 different medications. Jack's on a lot of new medications, and he doesn't really understand why. So the nurse makes a plan to start teaching them about their medications. And more importantly, how they're going to get their prescriptions filled. Since Jack can't drive, Diane never had a driver's license. They don't know how they're going to get to the pharmacy to get their pills. So the nurse starts making a plan for them, how they're going to get their medications, and teaches them why they're taking them and what's going on. The other thing Diane's really worried about is nutrition. She has diabetes, and she's very careful about making sure she doesn't have too much sugar in her diet. And she spends a lot of time with her grocery list and going to the grocery store and going to the farmer's market. And with Jack not driving, she's really not sure how she's going to be able to do that. So the nurse makes a plan with family and friends to make sure that Diane can be driven to the grocery store and to the farmer's market. A lot of people think, well, what about Meals on Wheels? But many of us know they don't currently have special diets for people with diabetes. So they're often filled with carbs or lots of sugar. And Diane really likes to cook and shop for herself. So the nurse is able to really assess the situation, provide education, and advocate for Jack and Diane. Again, no cost to the client and not billed to insurance. So usually when I pause on this slide, the next question is, why doesn't the VNA do that?
Right.
Excuse me. So many of us know the VNA has very strict criteria from Medicare and Medicaid of what they can and can't do. And there are two big kind of buckets in their regulation. One says they have to be homebound. So if you think about it, many would say, oh, Jack and Diane are homebound because Jack can't drive and Diane doesn't have a license. That does not make them homebound according to Medicare, Medicaid regulations. So the VNA cannot visit them. They also have a lot of needs, but according to the regulations, they're not skilled needs. So the VNA, as much as they would love to see Jack and Diane, they can't see them because of the regulations they're bound by. We talked a little bit about Meals on Wheels and other food and nutrition services. Jack and Diane don't qualify for Medicaid, so they don't qualify for a lot of these other programs. And the programs they do qualify, they don't have the low sodium and the low carbohydrates and sugars that Diane needs for her chronic illnesses. So when you really look at this graphic, the community nurse is in the middle of filling the gap that all of these other services can't fill, or maybe coordinating the care with those organizations that can fill some of these needs, but not all of them. The other
Yeah.
thing, go ahead.
Oh, no, go ahead.
The other thing, to think about of when I said advocating, a lot of what the nurse does in her ongoing care is talk about advanced care planning, not necessarily the documentation that we think about or the documents, but thinking about how are they going to plan for maybe hospice in the future or moving into an assisted living so that it doesn't come at an urgent crisis time and they're talking about a plan. Did you have a question, Anthony?
Yeah. So, well, more of a comment. So, I mean, so you brought up a great point in the respect that, VNH services, VNA services, throughout, Vermont and New Hampshire, there has to be that skilled need that is needed. The doctor's orders to be able to provide the support to individuals, and the community nurse connection is more of that, service coordination support, type of stuff that individuals need, especially, when they, prior to, going on to VNA services, or, they've now, quote unquote leveled up and they're, back to baseline and they don't meet the skilled need anymore. But they're, they still need some support or still need some help getting to and from, appointments, or, getting the groceries that they need for the home, or whatever the case may be. And so I guess to follow up with a question, so from the community nurse connection perspective, outside of, what you talked about with the, and excuse me, the little ditty about Jack and Diane, is there, is it more just the, the not skilled services that are being provided? Or, I mean, are the nurses able to do some of the skilled services that maybe they've technically, stopped being able to receive from the VNA, or is it just more of that kind of service coordination kind of thing?
Yeah, it's that term skilled need, which again, I don't like the term, because I think any nurse who does an assessment, that is a skill. And, our community nurses are highly skilled, but according to the Medicare, Medicaid skill, basically how I translate that is something that also requires a doctor's order. And the community nurses are independent. So anything, and according to the America's Nursing Association, anything that requires a doctor's order, a community nurse cannot do, because they are not working for a private duty or a skilled organization. So things like wound care that requires a doctor's order, they're not able to do. Vital signs they can do. We used to call it hands off, but when they do an assessment, they're touching and listening and looking. So they can do vital signs. But again, anything that requires a physician order, according to the American Nurses Association, they are not able to do.
Gotcha. And would you say, I mean, for the most part, for the individuals that are receiving services from Community Nurse Connection, are they, are they really just looking more for that service coordination thing versus the actual medical skilled need, that they would be receiving from, from their doctor or from us?
Yeah, and a lot of what the community nurses are doing is preventing decline. So trying to keep them stable. So maybe reducing a fall risk so that they don't fall and have that wound, or really looking at the feet of a diabetic to make sure there aren't new open sores. And then if they do find something, they reach out to the physician or to the VNAs and start another skilled episode if they qualify. So a lot of it is coordination and preventative care.
Perfect. Okay.
All righty. So the community nursing models, there's any way you define a community, you can have a community nurse model. So some work for the town, for example, Hanover, New Hampshire, that employee Doris works for the town of Hanover. Some work for a nonprofit or are contracted by a nonprofit, such as Aging at Heartland, Vermont. Some are members or employees of a church or parish, such as the Dartmouth Church of Christ. Lebanon has city employees, and some are regions. So Reading, West Windsor, the two towns have come together, and that nurse serves that region. So really, any way you define your community is a place to think of a community nurse. And I'm really excited to think kind of outside the box of towns and cities or churches, and really think about, some of the tribes we have in Vermont and New Hampshire. How can we embed community nurses to care for only the members of their tribe? So I'm really trying to think outside the box of community nursing models. So I talked a little bit about what the community nurses do and the gap that they fill, but a lot of times people say, well, what does Community Nurse Connection do? So as a reminder, the nurses do not report to us. They report to their town, community, church. So we're really just an umbrella support organization. One of the things we do, and we've done for 10 years, is provide startup grants for communities that are trying to lift up a community nurse project. So just this past year, we were able to give $5,000 to Stratford, Tunbridge, and actually Enfield, New Hampshire just applied for their grant. So we're really excited to be giving them that grant. We also provide ongoing small grants to the nurses. And this is really to help them provide or help them to stay current, or for them to provide care to their clients, to the residents of their community. And some of the grants we gave out this year were really, really interesting. So one nurse started taking Spanish lessons so she could care for the Spanish population in her town. One nurse really just needed a good pair of nursing shoes, and nursing shoes are expensive. So she got a nice pair of new clogs to help her do her job. We did have two nurses go and visit a paramedicine program in Maryland to learn about how they can work better with the ambulance folks in their town. So these grants, I tell the nurses, think outside the box. Like we want to give you money so that you can learn to do what you want to do. So that's one of the most exciting parts of my job. We also provide them with a confidential, secure data collection system. This is not an electronic medical record. So the documentation is very brief, very short. We build the forms, it's very confidential, and they collect the data on an iPad. And then we provide them with monthly reports on the number of visits they've done, the interventions they've provided, and then quarterly we have an outcomes report, and also fall risk prevention. Like, it's a very detailed report of what they've done. It's not an Oasis. It's not a hospice item set. It is, really, I think about 10 or 11 questions per encounter, just so they can, prove that they're making a difference to the residents they serve. Actually, just this year, it's not on this slide, but we've added a client satisfaction survey so that communities can collect satisfaction from the clients and then, make changes to their program. So we don't even have a report out yet. We're really excited to launch that. We facilitate a monthly community nurse peer meeting. We're not really even sure what to call it, but we provide space for the nurses to come together for an hour a month. there's really not a strong agenda. They share successes, they share challenges. And this is not always just with their clients, but it's about the community. And, how do we make sure that we're providing care in privacy when the neighbors are asking, it's probably similar to the VNA's issues of, it's not HIPAA, but we still want to make sure that the client's confidentiality is respected. But I love the meetings. These are some of the most highly skilled nurses I've ever met. And they come together, and to have them share ideas, and it's a very impressive meeting. And
Awesome.
then, oh, go ahead.
No, I was just saying awesome.
Yeah. And then a lot of what we're adding is consulting for, and it's no charge, but consulting for communities to learn how to fundraise, learn how to fund their program, or for new communities, how to set up policies and procedures. So that's kind of something we're adding to what we do to support the communities who are supporting the nurses.
So one question I do have, so again, obviously from the perspective of, the not providing skilled services to an individual that is a part of the community nurse connection, but do the nurses have the ability to access any medical records for the individual to kind of get social history or diagnosis history or anything like that that could potentially help them while evaluating a patient or anything like that?
Yeah, Dartmouth DH Connect has most of the communities have a contract with Dartmouth, so that they have a read only to their Dartmouth record. The clients have to give written consent though, because
Okay.
it's outside of the traditional healthcare system, so they can't access it without getting a document from the client signed that they fax over. They are able to communicate also in the Dartmouth in-basket communication. We are trying to get the nurses access to the Vermont system Vital, but it's been a little slow going to get them access because we're not bound by the HIPAA rules. So Vital is a little confused of why they would give access to a non-HIPAA entity.
That makes sense. So, and at least from the Dartmouth or the DH Connect system that you guys have access to, which I know, those that aren't in the medical record system that Dartmouth Health uses, DH Connect is a huge piece that they're able to use. And so within DH Connect, you mentioned being able to send messages through in-basket, and does that help in those times with needing to potentially have a referral sent in for a patient because the community nurse was able to, is seeing something that, maybe it would benefit if they, saw their doctor, saw a specialist, something like that. Is that an avenue that is utilized to be able to help with getting those referrals in place?
Yeah, I think so. It's usually not as much they're making the referral as they're communicating what they've seen, and then the physician, nurse practitioner, or somebody is like, oh, we should refer that. So not as much of them making the referral.
Well, okay, yeah.
As much as sharing. But I'm going to ask the nurses more about that, because they may say they make more referrals than I know they do. I know, like if it's VNH, Lake Sunapee, if they're thinking about home health care, they're usually just picking up the phone. All the community nurses, they have an amazing cheat sheet of contacts. Like they know everybody, and they know everybody's back line, and so they can usually get in touch with people faster using their methods than traditional methods.
Okay, perfect.
Okay, so I want to talk a little bit about starting a community nursing project. And I think the most important step is, if you're, for example, I'll use Enfield. I happen to live in Enfield. So, a lot of people were saying Enfield needs a community nurse. I was one of them. Like, why doesn't Enfield have a nurse? And what I quickly learned is you need to have 3 to 5 like-minded influencers inside the community to start a community nursing project. So I actually reached out to a friend of mine who's a nurse in town. And then we said, well, it can't just be nurses, because then they're just going to say, well, they're nurses, so they think they need a nurse. So we found a couple of other people. One of them happens to be a retired Dartmouth professor. And we were like, hey, will you join our group? We think this is a good idea. And, you're retired, you may need the services. So we found 5 people, and we would meet for coffee like once a month, and just start talking about why community nursing was important, why we needed it. And then we had to think about the model. Do we think this would be a town model? Is there another nonprofit maybe in town that would want to hire or contract a nurse? So we went to the town manager and we said, is there any possibility that, we could, the town would fund this position? And he politely said, probably not this year. There's been a lot that just passed of new taxes, and I don't think this is the year that people would embrace starting a community nursing project that is a town employee. So then we reached out to some other nonprofits and said, are you interested? And we had a few that were, but then the town manager called us back and he said, I think we can start a fund and we can fundraise for this through the town. So you don't need it to find another nonprofit, and we can test it for a few years before it goes to a vote of would we put this in the budget. So again, finding the influencers and then figuring out what funding you're going to go for. The next important thing, and a lot of communities have waited to do this, but you have to start identifying a nurse, usually from that community, who may want the position. I can tell you some of the other communities did all the other steps and have posted the position and can't find a nurse. So getting the buy-in from the nurse early, and then that nurse can help you with the next steps. So if you've, and you don't have to do these exactly in order, this is kind of recommended. Next, you want to think about a contract or a job description. So it all depends on, step 2 above your funding source. Will this be an independent contractor, or will this be a hired employee? And I want to pause there and say that this is really where Community Nurse Connection can help you, is, knowing the difference between a contractor and an employee. We have sample job descriptions and contracts. So we have all of this in place so that communities do not need to recreate the wheel. The next thing, you've got to create some kind of email or phone number to get referrals. I can't tell you how many communities have hired a nurse and then they are like, oops, we don't we don't know how to, an email. Like, so, again, this is what Community Nurse Connection is there for, to help make sure everything's in place. And create an outreach plan. How are you going to let people know there is a community nurse? And this is where the communities are really creative. Some of the nurses go to farmers markets. Some of them have a table at the library. One community, even the nurse set up a table at the post office, because that's where everybody goes to just say, hey, I'm the community nurse and I'm here to help. And then it's really important that the nurse gets the proper orientation. And what we can do is have new nurses go out with other community nurses to learn what they do. We also have a very comprehensive orientation to the documentation system. But if nothing else, you remember, it's that 3 to 5 like-minded influencers in a community, because it's grassroots, starting from the ground up.
Awesome. And
then a lot of people ask, how much does this cost? And so I for a while, I didn't add this in my presentation, but this was the most frequently asked question. So to start a project, usually the first year is about $30,000, and that's for 10 hours a week. We also really suggest an hourly rate between $35 and $50 an hour, depending on the nurse's experience. We have found you need highly skilled, experienced nurses to do this position because they're out there by themselves. It doesn't work with an LPN or a new grad. You really need experienced people, and you have to look around and be competitive with the other organizations if you really want a good nurse. So that is the suggested hourly rate we recommend. Also, the first year, there's some other costs, things like laptops, cell phones, marketing material, liability insurance, infection control supplies. Although those used to be harder to find than they are now. There seems to be a surplus of PPE in both Vermont and New Hampshire right now. And a nursing bag with equipment, blood pressure cuffs, stethoscopes. You need to make sure they have the tools to do the job. And then annually, it's really only about $25,000 a year for 10 hours a week. So it's not a high cost, but it's high value for the community that they serve. So I like to put this amount out there because there's a lot of people that go, wow, that you can easily fundraise that money for a year or two to get a program started.
And so based on your experience with the towns that currently utilize the community nurse connection, community nurses, did they all start with the grassroots campaign of fundraising and having those funds available for a couple of years, and then it became a line item on a town budget, or how do most of these end up coming to fruition?
It's really kind of all over the place. And I think at this point, I don't think any two communities have started the same way.
Okay.
We like to suggest that there's a year funding commitment because, you don't want to hire a nurse when you have 6 months of funding and then that nurse doesn't have a job if you can't raise more funding. We've only had we've had one community that did all the work to start up and then just couldn't get the money to continue the program. So we learned a lot from that one program of, you can usually come up with $30,000 so that nurse knows they have a year's pay. And then the nurse can help you get the money because the reports that we provide, the outcomes, it's easy once you see, the care that nurse is providing. 10 years ago when we started, there was no documentation system. Everybody was like, oh, it's a good thing, but we had no proof, no data. Now we have a lot of information. We're also starting to look at cost savings for the client. We've done a lot of talk of cost savings. Community nurses save the healthcare system a lot of unneeded costs. But then we started thinking, for every time the nurse prevents a hospitalization, we know it saves money for the healthcare system, but it actually, on average, saves that individual $300 copayment.
Right.
Especially for an unnecessary. I mean, if they need to go, they need to go. But if that nurse can prevent one unnecessary, that person saves $300. That's a lot of money for a lot of these frail elders in our communities.
Absolutely.
So hopefully next year we'll have a whole new slide on, client savings.
Excellent.
And I think that is about it. Again, I highly encourage you to go to our website or email, or if you want more information, please let me know.
Awesome. Yeah, and anybody who's watching this presentation after the fact, feel free to also reach out to the VNH. We can get you connected with Kristin and the team. So I just have a few questions. As we were going through the presentation, just that I'm wondering about. The first one, to talk about all the different towns that you guys are supporting. What town has actually started this whole campaign? I assume it's in the Upper Valley, or were there multiple towns that kind of all decided that they wanted to start this program, and then it's expanded from there?
Yeah, it was probably 12 years ago now. Dr. Dennis McCullough, who actually wrote a book, My Mother, Your Mother, about caring for his elderly mom. He was a geriatrician in the Upper Valley, and Lori Harding, who's a nurse in the Upper Valley. They started talking about these gaps in care, and mostly for frail elders, of when people didn't qualify for anything else. In the Upper Valley, a lot of people weren't qualifying for Medicaid, so these frail elders were falling through the cracks. So they started talking to parish nurses throughout the country about, what are you doing to care for your parish? They also started thinking back to like the history of the VNA, so the Visiting Nurse Associations, before Medicare got really involved. And there were things like town nurses. I mean, I grew up in a small town in Massachusetts, and we actually had a town nurse. And so they really started thinking about bringing back that model of care. And it was two parishes, one in New London and the Dartmouth Church of Christ, that they learned a lot about this community model, and then started encouraging other communities to think about how to provide the care. A lot started with aging in place nonprofits. So Community Cares of Lyme, Aging in Heartland. And I think Hanover was the first town to actually to hire a town nurse.
Okay, excellent. And so, obviously Community Nurse Connection is, like you showed in the first couple of slides, in very specific areas. A couple more coming in 2024, maybe more, depending on how things go or whatever. But outside of those communities, are you aware of other services similar to the Community Nurse Connection that just aren't a part of the Community Nurse Connection because of one reason or another?
We're aware of other community nurses. I've not been able to find another organization like ours that supports them. So there are other communities or aging in place organizations that have a community nurse, but they're kind of on their own. There's actually one in Westminster, Vermont, that I've been talking to about, and we don't have any membership dues. So for the support we provide the communities and the nurses is all at no cost as well. And we're inviting that nurse to join us so that she's not out there alone. But as far as we know, there is not another support umbrella organization.
Gotcha. Perfect. And so you alluded to it a little bit, in one of the slides, as far as the it being necessary that the individual is an RN that is more seasoned for nursing, to have that kind of experience, specifically, as you said, because they're going to be more on their own than having a well-rounded support network, potentially like at a facility or part of a VNA or something along those lines. I was just kind of wondering, what is kind of the specific reason related to that versus a seasoned LPN or a seasoned OT or a PT or something that has that medical training background, but again isn't an RN?
Yeah, I think for this model to work, and there are other models, community health workers, that are successful, but in a different way. I think it's the assessment skills of a seasoned RN. As a nurse, we joke, right? We go into a restaurant and we can assess the guy across the restaurant. We're like, oh, he's not breathing well, he's gray in his nails. So it's that high level assessment skill that an RN brings to this position that makes it successful.
Gotcha. Okay, perfect. And so those are all the questions that I had, and obviously I asked you a bunch as we were going through the presentation. For those that are watching this presentation live, if you have any questions, please pop it into the chat. For anybody who is streaming this after the fact, and you have any questions, again, go to the Community Nurse Connection website, which is communitynurseconnection.org. And you'll be able to, either find your local community nurse to be able to reach out to and strike up a conversation, figure out if, the supports are necessary, or I assume you can reach right out to Kristin, for overall, questions and support. And two, if in the event that, your community does not currently have a community nurse, to be able to potentially start that process and get a community nurse into your community. So Kristin, before I let you go, is there any additional information that you want to get out to the people who are watching this?
I think you just said it, Anthony. If you live in a community and you don't have a community nurse, be curious, find out why. And, I'm happy to help answer those questions. But, think about where you live and your friends and neighbors, because I'm sure some of them could benefit from a community nurse.
Perfect. So, well, Kristin, thank you so much for taking the time out of your busy schedule to be able to provide this great informational piece about the Community Nurse Connection, so that way we all have a much better understanding of what it is, what's involved, and how and maybe most importantly, how you could potentially ensure that your community also has a community nurse moving forward.
Thank you, Anthony.
All right. So, and thank you all who were watching this presentation live or are streaming it after the fact. We will be back next month for the next installment of Let's Talk, presented by the Visiting Nurse in Hospice for Vermont and New Hampshire. Thank you all.